introduction. I'm a consultant pharmacist in gastroenterology, and I'm really passionate about developing the next generation of pharmacists. I'm involved in national groups and looking at workforce planning. Next slide, please. So I'd been asked to talk about reflux and GORD, and I just really think that you need to understand the anatomy and the pathophysiology of a disease. You need to really be very clear what are the complications and the risk factors to be confident in counselling, and you need to really be very astute in recognising the red flag symptoms. And then, of course, we want to be able to manage the diseases and counsel the patients in a correct and safe manner. Next, please. So we're just quickly looking through definition of GORD and reflux, anatomy, risk factors, complications, a bit about the epidemiology. It's not as prevalent in every country. Red flag symptoms. I want to talk a bit about management, which is obviously the core of pharmacy practice, and side effects, ADRs and DDIs. We are just, what is reflux and GORD? It's dyspepsia is just any upper abdominal pain and discomfort which comes with heartburn, which is reflux, so the content of your stomach reflux. However, GORD is a chronic condition, whereas dyspepsia is anything which lasts longer than 4 weeks with these symptoms. With GORD, it's chronic, and it's usually proven with endoscopy, it's predominantly heartburn, and you can acid regurgitation. So the endoscopy will also show if you have esophagitis, which means that your esophagus is already inflamed because of being attacked continuously by acid and pepsin and bile. There are some very few conditions which are like GORD, but they're not endoscopically proven. They can't show any inflammation, but we still have to treat them. So in the next, we just very quickly, it's a continuous chronic reflux of the gastric content. So you have the acid, the bile, and the pepsin, which are all, of course, attacking the tissue which is not like the stomach, and therefore can cause inflammation. Why does it happen? It's usually 3 reasons. You have the transient relaxation of the lower esophagus sphincter. The lower esophagus sphincter is a sphincter which is supported by the diaphragm, which closes the stomach against the esophagus. And you can have conditions where it doesn't work very well. So either it's just transient, which is about 65% of all reflux, but you can have also a pressure on your stomach because you have a too full stomach, you're pregnant, or you do too much exercise, which then pushes the acid through the closed sphincter into the esophagus, which causes the burning sensation. Or you get spontaneous reflux without that, if your lower esophagus sphincter is permanently relaxed, so is hypotonic. We have to say that most of the reflux actually has not got many symptoms. It really depends on where in the state of the day your gut content is. So after meals, your gut content won't be too acid, so any reflux won't be so painful. Next slide, please. So the risk factors for developing GORD is obesity, some foods, smoking, pregnancy, stress particularly, and of course there is a familial history of GORD, and it's more likely. Particularly interesting is hiatus hernia, which is part of the stomach, goes through the diaphragm, and it prevents the sphincter working properly. But you also have drugs which cause GORD, and they are obviously the non-steroidals, steroids, all these. And what you have to do is you review them, you use the lowest effective dose, and if it's a prescribed drug, they need to go back to the GP or to the prescriber and say, can it be stopped? Can it be changed? And if it's over-the-counter drug, your skills should be able to really make a decision. Do they need to change? Can they continue with the medication at the lower dose? Next, please. So the complications are obviously inflammation of the esophagus. You can have hemorrhages, you can have strictures, but the really bad complication is when you have esophagitis, where the tissue changes on the lower esophagus, and it's called Barrett's syndrome. And about 10% to 15% will develop Barrett's if they have this chronic condition, and about up to 10% can then develop this into a cancer. The prevalence is particularly in North America, Europe, so it's in the developed countries, but also the Middle East, South America. So it is very prevalent. On the next slide, you see, I just thought it would be nice to just see the red countries are the ones where it's very prevalent, where you have a lot of GORD. The blue countries are interestingly not so prevalent for GORD. Next. So red flag symptoms, it's really important that you recognize which patients need to be referred and which patients need to be referred urgently. This is what we do in the UK. This is the nice red flag for GORD. So if you have appetite loss and weight loss, or you're bleeding, you need to be referred. It's not totally urgent, but you should be referred. However, if any of these symptoms or presentations are together with weight loss, so dyspepsia with weight loss, plus you're over 55 or you're a child, if you have a mass, which sounds like stomach cancer, if your reflux is with weight loss and over 55, they need to be immediately referred. In the UK, we have a 2-week rule, so a GP can refer the patient under a 2-week rule to be to access endoscopy immediately to, of course, exclude cancer. So what the next slide is showing us is how do we manage GORD? So first of all, make sure there are no red flag symptoms. I personally always think if you offer advice, make sure you have some written information and advice on the symptoms and self-care. Patients are can only usually take in 3 things. So if you have a written leaflet, they have time to read it afterwards. The most important thing with managing GORD is really lifestyle change, lifestyle advice, because changing your lifestyle can improve the symptoms drastically. If that hasn't worked, you can offer some antacids, and if that then really doesn't work, you probably need to refer them or often have a trial of a PPI. Next slide, please. So in the NHS here, the UK, has a really good leaflet which you can download, and it tells the patient the do's and the don'ts. So, you know, eat small amounts, don't exercise when you're after food, limit your weight, but it also says don't have food too late in the day, do not smoke, and all these kind of, you know, advice. So what medication in the next slide are we going to look at? The treatments, as I said, is lifestyle advice. It's the most important thing we need to do. Anybody overweight or obese needs to lose weight. It's the best thing you can do for reflux and GORD. Of course, avoid the trigger foods and eat smaller amounts more often and not late at night. Stop smoking. But what's really helpful too, particularly because your acid excretion is mainly at night, or the highest amount is at night, you raise your bed. But don't just have a cushion, raise the whole bed. If you have a cushion, you squeeze your stomach again because you're leaning slightly forward. So if they raise the bed, they have to raise the whole bed. So you're at an angle. Look for stress anxiety management, and obviously ask them about their over-the-counter medication or any personal medication. Just review the medication. What do we use? We can use antacids, and if they have proven GORD, so they know they have a chronic disease, you give them 4 weeks of a PPI to healing, and then they can stop. So you can give them intermittent. If the person has severe esophagitis, you probably need to give PPI long-term and possibly even double the dose, depending on the symptoms. So you give 8 weeks for healing. Esophagitis takes longer to heal. And if you probably for maintenance, you need to continue with the PPIs. H. pylori tests are always worth seeing. Is it all driven by H. pylori? Next, please. Of course, we need to talk about pregnancy. GORD and reflux mainly is very prevalent in pregnancy. You've got, as I said, the pressure on your stomach by the growing fetus, and therefore the content of the stomach can pass through into the esophagus despite the sphincter normal sphincter pressure. Again, it needs lifestyle modification, antacids. Sometimes antihistamines, if the antacids fall. PPIs really should only be used in patients, in ladies who have intractable symptoms, so when we can't get on top of it. Please don't recommend nisatidine. It's not recommended in pregnancy. Don't use long-term. They should just use it intermittently, as little as possible. And please don't use sodium bicarb containing medication, so the fizzy stuff, because it can give them sodium overload or fluid overload and acidosis. So, however, you know, only a minority of patients will need to step up from antacids. Most pregnant ladies will be managed with antacids. Next. So how do antacids work? Well, they basically, it's chemicals. They neutralize your acid, the chloric acid. You've got aluminium, calcium, magnesium, and bicarb containing antacids. They all probably work as well as each other, just you need to optimize it for the patient, you know, which one do they prefer. However, be aware, all of them will have side effects. So you get, particularly with babies and the over 65s, you know, be careful in certain conditions. Some cause constipations, like the calcium and the aluminium, and of course, magnesium is a fantastic laxative. It will cause diarrhea, and bicarbonate will cause bloating and flatulence. Alginates, they just form a raft on top of your stomach, so the acid can't go through, and they're usually used in combination with an antacid. Prokinetics, I wasn't really going to talk too much about it, but we need to talk about, because you might come across a prescription for metoclopramide for gastric emptying, to help gastric emptying, because of course, if your stomach doesn't empty well, you're more likely to have reflux due to the pressure in the stomach. And next slide, the PPIs, how do they work? They work on the H2K ATP exchange, so the hydrogen potassium ATPase. They block it, and it probably blocks about 70% of acid excretion. And they last very short-lived, so doubling the dose might be a really good way of helping. But again, this is usually reserved for really symptomatic GORD and esophagitis. You've got the antihistamines, which work on the parietal cell and prevent the histamine working, which is involved in the HK ATPase pathway. So yes, we can deal with it, but just be very aware of the side effects of these medications. So on the next slide, Oh, here's the PPI dosages. These are the ones recommended in the UK. I presume everybody has very similar. So we have the full and standard dose for all the PPIs available, low dose, on the demand dose. I particularly like on demand dose because most patients need a duration of treatment and then can stop again. And then you've of course got the double dose, which we're using in Barrett's and esophagitis. Next slide. The side effects of the PPIs, I really like you to be aware of them. I won't go through them. What for me is important is that you reduce magnesium absorption, calcium absorption, iron absorption. So if somebody takes them very regularly, they probably should be managed. You obviously have problems with infections because your stomach acid reduces the bugs that go through. So I'll leave that for you to look if you have time at the later stage. Next. Antacids, again, are very similar. You have problems when the patient has concomitant diseases, kidney disease, heart disease, because you affect the electrolyte balance in the stomach. So you can get constipations, you can get hypomagnesia and hypercalcemia. So we really need to be very careful who we recommend it is, and it has to be tailored to the patient. Next. So the last slide is really what I also would like you to be aware of is the drug-drug interactions with antacids. They're not just easy drugs. You're the specialist, you will be recommending. So think about drug-drug interactions where they can worsen renal and hepatic impairment through electrolyte imbalances. And also think about over-the-counter medications patient might take, which affect the effectiveness or which can counteract what we're doing. But what's really important is through the increase of the pH, some certain pH sensitive formulations won't be released, and sometimes it affects the stability and the solubility depending on the gastric pH, which you, of course, with antacids are affecting. The same with PPIs, but this is really something you need to be aware how antacids or how the change in the gastric pH can affect all sorts of formulations and stability. So at the end, what I'd like you to do is make sure you offer them lifestyle advice. It's really important. You use the shortest course of PPIs possible, and also identify the red flag symptoms, and always consider the whole patient. As Gonzalez said, you know, we think about comorbidities, the other medication, where are they in the life, what's fitting with the lifestyle. And that's hopefully given you a very quick help with managing patients with reflux.